The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone, and welcome to Leading Age Michigan's Safe and Calm webinar for February 17th, 2021. My name is Dave Herbal, and I'm the President and CEO of Leading Age Michigan. And today we're coming to you from chilly East Lansing. Just to start the program, I'd like to just make a few comments. While the positivity rates continue to decline in our state, we still have 38 counties in Michigan with restrictions on visitation. Today we have two guests with us from Move Communications, Ashley Edwards and Don Hart. Ashley and Don are joining us today to express to you our forward-facing communication campaign entitled Give Seniors a Say. Giving Seniors a Say is a Leading Age Michigan board initiative designed to engage members, families, and staff in advocacy for putting the voice of seniors back into the discourse on policies that affect their lives. I'd like you to welcome Ashley and Don today. And Ashley, when you're ready, take it away.
Thank you, Dave. Thank you, everyone, for having us today. We're really looking forward to being here and working together. I'd like to take you through what our strategic objectives are for this campaign, explain how we'll be executing it, show you some of the creative, and then also discuss the engagement levels that we would love to have you involved with. As Dave mentioned at the beginning of this call, we're still facing a lot of restrictions regarding visitation, and we have extensive experience working with senior communities, and so we understand firsthand how this really affects the residents, the staff, the whole mood of all of the facilities. We've experienced loss, and we've also experienced great joys of seeing some of these staff really pull together and support the seniors. But ultimately, visitation is a very important part of the physical health, the mental health, emotional health. One thing that I do want to point out about visitation specifically is it's an example of a bigger issue at hand, which is ageism. And throughout the years, senior voices have been not heard or dismissed. And this really came to a head with COVID, when all of the visitation restrictions were put in place. These seniors or their advocates were not consulted, and it has a drastic effect on their quality of life. And it's time for us to help give them a platform. And that's why we've developed Give Seniors a Say. We know that this particular visitation issue related to COVID is just one of many other issues, and it's something that we can immediately speak on today. But going forward, Give Seniors a Say will be a platform for all senior issues. And we hope that by providing this unified platform, that we're empowering the residents, their families, those that care for them and their champions to support our seniors. It seems that, unlike many cultures around the world, Americans often value youthful energy and excitement over the wisdom that comes with age. And even in our work with other senior living facilities, we've heard from our seniors that despite their experience and wisdom, they're still treated as less than by the general public just because of any kind of physical decline. We have residents who have multiple patents, who have been CEOs, who have been teachers and nurses, and nobody takes the moment to listen to their story and appreciate everything that they have given our generations. They're not a burden to be dealt with. They're the experience backbone of our state and our society, and they deserve our respect. And so using visitation as our launching point for a very critical issue, we'd like to present to you, Give Seniors a Say. And what do we hope that will come out of this campaign? What we want is to make the general public, the families of seniors, to be aware of their collective right to have input in the decisions that affect them, including day-to-day living and care. And with this lift in awareness, we hope to see the inclusion of seniors in the policy decisions that directly affect them. And we'll be able to measure the impact of our campaign through a variety of ways. We'll be launching a PR effort, paid media, and so we'll be able to measure the number of media interviews, on-air appearances, website traffic, Facebook engagement, and video views. And I'll get into the tactics on these next slides here. We want to build momentum, starting with our community leaders and our influencers and our most fervent advocates, the adult children, the leaders in the senior living community, and of course, most importantly, the seniors. And this is why we're very excited to work together with Leading Age and all of its members to help bring this to life. I understand, we all understand that everybody is taxed and maxed out with COVID protocols and just the day-to-day operations of the business. And so we just ask that you keep this in mind as a resource for your family members who may have concerns over visitation. You can urge them to take action. You can distribute some of these materials throughout your community. And if you really want to be active, we'll have more tools for you to use. So let me show you what those are. We have prepared for you a toolkit and a guide, which we'll have available to you through the Leading Age website. We have both a toolkit, which is a 22-page document that outlines the entire campaign, provides you with letters to the editor, samples, sample press releases, sample Facebook posts, anything that you would like to use from that toolkit to help mobilize and support Give Seniors a Say. It's all available to you, and that will be on the Leading Age member portal. We'll also have a member toolkit, which is a pared down version, and this can be for the seniors and families to advocate directly for themselves. We'll have a landing page on the Leading Age Michigan website. It will have, the URL is giveseniorsasay.com, and we'll have all this information available, education on issues, press releases, and other resources on how you can petition your local decision makers to give seniors a say. One effort that we're working on this week are video interviews with executives, staff, and residents themselves, with the hope that by sharing these stories directly and making it available to the media, we will be able to help get these voices heard. Here are some examples of what's included in the advocacy guide. For example, we have talking points about explaining the situation, the impact, the call to action, what we want people to take, what action we want people to take. We have sample Facebook posts. Here's an example of the news release and the fact sheet. And tips for your marketing folks and PR folks for tips on how to send news releases to media and follow up on pitch calls. We understand that not all of the members may have a PR representative, and so we want to help support you in this way by giving you these tools. You can also identify your legislators, and you can make this available to your members and their families. Bringing this campaign to life, here's an example of what could take the form of a print ad, or could be a flyer that you distribute to your residents in their mailboxes. It could be a piece that's printed and mailed home, or even sent electronically. And it really encapsulates our campaign. So no matter when or where we were born, our experiences make us wiser. Seniors should have a voice when it comes to decisions affecting their lives, whether that's legislation, living arrangements, or other issues. Visit GiveSeniorsASay.org for more information on how you can help. And we can make this available to you, the membership, if you have a print media buy that you're already running as part of your campaign. We can give you these files and you can put your own logo on it and also submit it as part of your media buy. Or like I said, you can have it as a handout in your own facilities. I spoke a lot already about the landing page. The landing page will be ready this week with the toolkit and the advocacy guide. And by next week, we'll have the video up on the site as well. We'll be continually updating the content on this site. So be sure to check back frequently for any other resources or news releases that we'll be featuring on here. We at Leading Age, we will also be doing our own Facebook posts through the Leading Age page, but you're also welcome to either share or reuse this content. We will also have a calendar available to you through the member portal that will have images and text that support this campaign that you can copy and paste into your own social media channels. Very similar to other campaigns that you've seen from Leading Age. We'll make those resources available to you. As I mentioned in the beginning of this meeting, I completely understand that everybody is underwater, overwhelmed with COVID and visitation right now. We're really hoping that you'll collaborate with us as a member of the LMI community. And we really also hope that you'll join us in advocating for these seniors. Whether it's making these resources available to families or whether or not you're reaching out directly and contacting legislators, any type of support that you can provide for the campaign will help it go a long way. So we really appreciate that you're willing to entertain our campaign for you. We'll be also ramping up paid media and PR opportunities leading towards May, which is Older Americans Month. And as you reflect on this campaign, if there are residents or family members that you feel that we should speak with that have a compelling story, we're happy to speak with them and include them. We'd like to get as much momentum out of this as we can.
Ashley,
And that concludes our presentation, and I'll turn it to Don if he has anything else to add. And then of course, we're happy to answer any other questions that you may have following this.
great. Thank you so much, Ashley, and thanks to everyone. I put myself on camera so you could see me for a moment. I'm actually in Traverse City right now. I live downstate in Ann Arbor. But that's one point, is this is a statewide effort, as is, LMI. And we want to be able to, be able to work with you in all the various locations around the state. If you had sort of a vision of what we would like to see, it's people feeling now empowered, seniors empowered to say, hey, I want to give expression to some of my concerns or to my stories, and you'd see the tide rise of the things that they're saying, and that eventually really becomes an influence. It's if you will, if there was a wave after wave of concern and insight that's coming from seniors that will influence legislators and the public at large, through the compelling stories with emotional impact and articulated insight. That's what we want to see grow. And you all are those who are closest in, and you might know an individual or two that right now you would say, hey, giving this guide to them will give them some more hope. It will feel like they're not just treading water or they're swamped, but they really can actually take an action now. And as they do, they're going to share that with their friends. And then, there will be an impact through that. So we're hoping to actually reach out to you and, personally, so that we can see how it's working for you, what we might adjust, and together really take steps forward that we joyfully can say, wow, we've really seen a change, and we're excited about the positive things that are happening. And now I think we're opening it up to questions. If you have a question for Ashley or for me or for Dave about this effort, that would be great. And I'm going to go off camera now. Thanks.
All right, we'd like to thank both Ashley and Don very much for joining us today. Let me go ahead and pull the questions up really quick. So right now it actually looks like I just have one question for you guys, and that is, can we please get a copy of the Give Seniors a Say presentation? So if you guys would be willing just to send that to me, after this webinar has always concluded, I send out a copy of the recording of the webinar as well as the PowerPoint. So if you guys just wanted to send me that PowerPoint, I can send that along to everyone as well.
Absolutely, no problem. We can also make this available for download through the member portal as well. So happy to do both.
All right.
Absolutely.
Sounds good. Thank you very much. So with that, I am not seeing actually any other questions come through. So I think that we will move on to our regularly scheduled Safe and Calm webinar. So again, thank you very much to Ashley and Don for both joining us here today.
Thank you for having us. We appreciate your time. Thank you.
All right.
So good morning, everyone. Again, this is Deanna Mitchell with Leading Age Michigan, and I'm sure that if there are questions about Ashley and Don's presentation moving forward, we'll certainly get responses to you. This morning, from this point on, we're going to follow our standard agenda. Dalton's going to be talking a bit about our advocacy and the current proposed budget that's out there. We'll follow with the situation update, and then we're going to move on to several small updates to guidance. There's been a lot coming out from the CDC this week. So with that, we'll turn the mic over to Dalton, our Director for Public Policy.
Good morning, everyone. So as a follow-up to the Give Seniors a Say presentation, I wanted to touch on kind of where our advocacy is with visitation right now. If you've been on the last couple of calls, you'll know that we did send out a number of letters to key policymakers and to the governor and to Elizabeth Hertel, the director of MDHHS. We have been getting response back, and we've reached out to people on both sides of the aisle and in the legislature, and they have really been receptive to what we're saying, and they have taken some of our policy points and actually our letter directly to conversations with the governor. So we are making some progress there right now, and as we get this Give Seniors a Say campaign rolling, I'm really excited to see where we can go with all of this. So as we talked about last week, we discussed a little bit about what the budget process is like. This image here is the actual budget process in a visual form. And the important part, I'm not going to go through all this, there's really two key things. Firstly, that they like to have the whole budget negotiation process done by June. So that's why you'll see them starting to propose things in early February, early March, late January, because they are trying to get it done by June. As you know, last year we got really close to the end date. In fact, I think they got it done on September 30th, and they needed to get it done by October 1st. And things in Lansing have gotten even more political over the last year. So our expectation is that they will not hit their June target, but we do think they'll get something done in time. So we'll see what happens with the timeline, but just know that the target is mid-June. And then lastly, the upcoming, lastly, I guess, for this slide, the important thing to note is that the following information will just be what the governor has recommended for her budget. So these are recommendations that she proposes to the legislature, and they are not actually in the budget yet. They're just kind of ideas on paper and a starting point for them to work with. We do know that some of the ideas have been received well from the legislature, but others have not, and they really are still getting their hands around the whole thing. I believe either today or tomorrow, for instance, the Senate Appropriations Committee will be looking at the DHHS budget in itself. So that'll be really the committee's formal introduction to the budget. So that's kind of the important parts of the process to know when we look at the following information. So as you may or may not know, a majority of long-term care's funds for the year come in the DHHS budget. Just some general facts about that budget that the governor proposed. She proposed total ongoing funding of $31.5 billion, with 5.2 coming from the state general fund. The state general fund is the portion of the funds that are actually state dollars, and the rest is federal dollars given to the state in some form, whether that be like a match program or just budget dollars. They come in various forms. It got cut off a little bit by the image here, but the proposed budget she has $100 million in one-time funding total, with $48.1 million of that in state general fund dollars. And one-time funding is just extra funds that they're going to use specifically for that budget year. So there's $100 million of that. And then for the next fiscal year, she's recommended a budget of 31.6 billion, with 5.6 coming from the state general fund. 5.6 billion, that is, and that number will go up because of at least right now, the reductions in federal funding that will be coming to the state 2023, because we won't have all the same COVID relief dollars coming into the state, at least for now. So here are the proposed budget items, and you may have seen some of these come out in a member update. I believe it was Friday, but I did want to clarify a couple of things on some of these points, because really, there's two issues in some of these. For instance, the $360 million to make the direct care worker wage increase permanent. There's actually two issues here. One is actually making that $2 an hour permanent. And then the other is that they need supplemental funds to extend the program for the remainder of 2021. Because this budget is talking about next year, which then leaves the time frame between when the budget goes into effect and I believe it's February 28th coming up here with no funds for the program. So they'll be working on getting some funds into that program. This has been generally well received, but we have been advocating to make sure that it is still a wage pass-through. We believe, and we've been told that that is kind of what they believe, or what they think it is, but the governor didn't really give us straight details or language that says that. We don't want this to be some kind of a mandate put on to long-term care providers. And I don't think anyone thinks that. She called for an extension of the $2 an hour, but didn't mention it as a wage pass-through. Next is $37.5 million for nursing facility support payments. These will be one-time funds given to you as an increase in Medicaid payments. These are meant to cover low occupancy or low census in SNF providers to act as a bridge or to help SNF providers get on the path towards recovery. There's also $23.1 million for enhanced FMAP redetermination. Essentially, the state needs to add more funds to balance out that program. There's $19.1 million for the My Choice program. This is for an additional 1,000 funded slots for home and community-based services throughout the state. So they're looking to expand the My Choice waiver program. Some other ones that I put on the second slide that I think will be of interest, but they're not as, I think, directly related. There's $5 million for a home health and safety pilot. This is to promote sound construction and renovate buildings for home health care. There's $2.1 million for a DHHS race equity, diversity and inclusion office to be established within DHHS to review their policy. There's $1.1 million to continue supporting the state infection control surveys and SNFs. And there's $6.1 million to modernize the state licensing systems for CNAs and substance abuse disorder, which I think is welcome since the licensing, at least the licensing program at the state, in my opinion, it feels out of date. It feels a little out of touch with what we're doing in the modern day.
All right, thank you very much for that, Dalton. Let me go ahead and check the questions here, but before we actually do check any questions, we did just want to show you a couple things and give you a couple reminders as far as our website goes. So I'm going to go ahead and pull that up on the screen here really quick. So basically the quick reminder we wanted to give you, I guess, one, I will say once you do come to our landing page, you'll see the Give Seniors a Say banner right here, and so you can go ahead and click that, and that's going to take you to the web page that Ashley was talking about earlier, and we will have more information and more things added to that as we go. Additionally, we did want to mention that if you do have an account with us, I just signed out here, so we can go ahead and sign back in as me. Just wanted to remind everybody to go ahead and update their profiles if you can. So obviously you'll go in here, you'll see me, Blake Weller, here at Leading Age Michigan. So you can go ahead, and if you'd like to, you can update. You can go ahead and put a picture on there. You can go in and manage your profile from here, edit your bio, and you can, if your email is still the same, or if you're having trouble maybe getting our emails or something like that, you can go ahead and check and make sure that your email address is correct, so you are receiving everything. Make sure that obviously you have the correct name. Try to update your organization if possible, maybe if you have a new title, things like that. Just trying to make sure that we have all of our member information basically as up to date as possible, so that would be awesome if you guys could go ahead and do that. Also, I figured that I would show you, since every single time that we have any type of education, I always say that you can grab your certificate or your CE certificate from the professional development section. So I just wanted to show you, I guess, how to get there. So again, you would go to this manage profile section, and it's in this content and features area. You'll see professional development, and you can go ahead and click on that. And then you'll click on this certifications and programs. I don't have anything because I have not filled out a survey, but if you did, you'll see every survey and every certification that you have done with us will be saved on there, and you can go ahead and grab those certificates off of there. So I basically think that that was everything that we did want to show you. So thank you for that. And it actually does not look like we have any questions, so we can go ahead and move on, Deanna.
Okay, well, thank you, Blake. We will move on to the situation update. And you can see that in the slides ahead, that Michigan is in the leading group of states whose caseload numbers have been markedly improving. Go back to the other slide, please, Blake. And yet the CDC believes still that although the country is improving, there's still a lot of transmission in many states, and some experts are predicting a fourth wave, mostly due to the variants that are now spreading in Michigan and elsewhere. So it does look optimistic right now, but we still have some concerns moving forward. Here is the CDC map for the 7-day average number of cases by state. Last week is on the right, this week is on the left. Again, Michigan is one of the handful of states with comparatively low transmission, but you can see that many of the other states have improved over the past week, and there's less blue on the slide on the left. We developed this slide yesterday morning, and I believe that the number of variant cases in Michigan may have grown since then. But even as of yesterday morning, you can see that the 29 UK variant cases from last week grew to 61 as of yesterday morning. And cases have almost doubled for the UK variant in the US over the past week. The other variants, which might be a little bit more troublesome, they are still less prevalent, but then again, they might be problematic in the near future. Here's our standard caseload graph as of the 15th. You can see that overall in Michigan, cases are still slowly decreasing. The 7-day average number of deaths has stabilized, but you will see some up and down movement across the past week or so. But that's really due to the batch reporting of some deaths from the health department. This week, we changed the format for the county positivity rate graphic. So this time we graph the trends over time for each individual CMS positivity rate category. And I think that it's a little bit easier for you to see the changes as the red counties have gone down. Obviously, the green counties have gone up, which is extremely positive. You can see that the red category has decreased so far as 2 counties only using the CMS positivity rate. And yet, as of this week's data in Michigan, and this week it was updated Tuesday instead of Monday because of the holiday, there are still 38 counties in level E. And using the CMS criteria, only those 2 red counties would have been significantly limited in visitation, while in Michigan we still have 38. In terms of nursing home resident caseload, we have seen continued declines. It is getting very, very positive looking in that respect. The numbers for homes for the aged had a slight decline, appears to be stabilizing. And the numbers for AFCs, we saw a slight boost in the number of new cases in adult foster care. And of course, all 3 of those slides are about residents only. Looking at all of the Michigan long-term care facility data, we can see that, as the slide showed, that the new resident cases are declining. But we also note that the staff case rates are a bit higher. We're wondering if this might be due to the high numbers of residents who are now vaccinated. We're not sure. We'll have to continue to look at that. It's unusual a little bit for staff cases to be higher than resident cases. Overall, we have well over 43,000 long-term care facility cases, including staff and residents, and almost 5,600 deaths. So we're going to move on to our updates. We pretty much have not any dramatic changes to guidance that have come out. Both CDC and a few MDHHS new recommendations have come out, but they've tweaked an awful lot of pieces. So we will go through them. Starting with vaccine updates. This week, the department issued an update to its priorities for vaccination in Michigan. They continue to work on a strategy to ensure that more diverse populations have an equitable access to the vaccine. They are also now including mortuary workers as part of phase 1. Additionally, in order to make sure that the vaccines are getting out to persons with less access to health care, they're going to be shipping vaccines to the 41 federal qualified health centers across the state. This is specific to assist in vaccinating seniors. A lot of these clinics are in rural areas and areas where there is limited access to health care. Also, starting March 1, they're going to start to vaccinate food and agricultural workers. And again, they restated their goal to have 70% of the state vaccinated as soon as possible. So this data is from the MDHHS vaccine dashboard. It shows the number of vaccines per age group. And you can see on the bottom graphic there that seniors do have high numbers, specifically for their first doses. And overall, at this point, 13.8% of the entire population in Michigan has been immunized with a first dose, and 6.3% have had second doses. We are a bit concerned this week about potential delays in vaccine distribution because of the weather, but we hope that that won't be very dramatic. The department has also issued several recommendations and reminders about the vaccines. For the pharmacy partnership program, the CDC has left the decision up to each state whether to allow a first vaccination at the third clinic. MDHHS is highly recommending continuing first doses at this third clinic. So for residents right now, if they get a first vaccine at the third clinic, Facilities should work with local health departments for a follow-up vaccine plan. And for staff, they can either go through the local health department or the retail pharmacy program. And those retail pharmacies should start to receive vaccines shortly for those second doses. After the clinics are over, it's expected that each facility will need to find an enrolled pharmacy through the retail pharmacy program. And in Michigan, those pharmacies right now include Meijer, Rite Aid, and some of the smaller Cardinal pharmacies. However, these pharmacies will continue to follow the priorities set by MDHHS, so they will not be immunizing anyone that isn't in one of the priority categories. We also want to note that one of our members has informed us that when they checked MICR for vaccination status following their clinics, they found a lot of errors. So we're suggesting to our members that they might want to take a look at MICR to verify the accuracy of what some of your pharmacies might be listing as residents with vaccinations. There's some that had been listed as vaccinated who weren't actually in the facility, and some it appears that they may have missed. If you find problems, we would suggest that you first discuss it with your pharmacy and then go to MDHHS if necessary. So more information on the entire program for retail pharmacies is at the link on the page. CDC updates have also been issued in the past week, and we've already talked about the first option, which is how long-term care communities can continue accessing vaccines after the ending of the pharmacy partnership program. They also, though, cite some possibilities, but these, at this point in Michigan, as far as we know, these are just possibilities. We've not gotten them confirmed yet about what Michigan's going to do. But the second and third option really talk about facilities that could either assist the retail pharmacy or become the provider for the vaccine itself. Right now, the pharmacy is serving that provider type role. And what that would mean, especially for option 3, that would mean that facilities would have to store the vaccine and also to register in MICR to report vaccine administration. And as I said before, we're not sure whether or not that is the plan for MDHHS or not. We did hear several weeks ago that there was no intention of having facilities manage the vaccine until there was an option that did not require ultra-cold storage. But that may have changed, and we have put out a question to MDHHS to find out what their thinking is currently. We have not heard anything that facilities should prepare for that kind of work, but again, we're waiting for MDHHS to give us an update. The CDC has also put out updated guidance on the currently approved vaccines themselves, the mRNA vaccines. These are mostly for providers, and there are some small clinical updates and reporting. There have been some changes in terms of quarantine for exposures that are included in this guidance, but we'll talk about them because they're also covered in other guidance later. The link for the clinical considerations is at the bottom of the page. The CDC also finalized some updates about masking. Initially, we heard that experts had varied responses about whether double masking would help address the potential higher transmission rates for these variant strains of the virus. The CDC has now completed a study and has determined that double masking is helpful. The findings from the study are on the left side of the slide. I was surprised to hear that cloth or medical masks only block 40% of particles, but that's what this one study said. Apparently, the biggest issue in properly masking is still the fit of the mask and how it is attached to the body. Simple ear loops are not recommended, and that was a bit of a surprise to me as well. So there are 3 separate sets of CDC guidance on this, and they're all listed here on the slide, and I would suggest that everyone review those. There's a lot of information that's new in there. So NDHHS followed suit, followed those CDC recommendations and issued a recommendation for double masking as well. Although they don't really seem to discuss the need to address the ear loops, the CDC reports that they should be knotted and tucked under, but the state does recommend masks with 2 or 3 layers. So this is a graphic that they sent out this past week about what's recommended and obviously what's not recommended. And again, since there's been some significant changes in masking, we suggest all of our members do review these guidances. Over the past several weeks, we've been hearing more and more about counterfeit masks. Apparently, they've identified 1.9 million masks that were labeled as 3M products, but in fact were counterfeit. The first alerts were that these masks were misshapen, out of shape, and odd smelling. In testing, though, when testing these counterfeit masks, they did find, and these are N95 masks, by the way, they did find that they do filter about 95% of particles, as other NIOSH N95s are supposed to do. But they had higher breathing resistance, which caused fatigue and often caused people to take off the mask for a while so that they could breathe easier. So that's obviously, an issue. So a report from Kaiser Health Network also identified that a lot of the KN95 masks are suspect. And even those approved by the FDA are not performing as expected. And this may be the reason why MyOSHA does not allow KN95 masks at all if you're caring for suspected or confirmed COVID cases. So for those of you who are relying on KN95 masks, you might want to look at that. We tried to identify pictures of counterfeit masks, but there were so many different pictures of counterfeit masks, I found it overwhelming. It is important to note that legitimate N95 masks never have ear loops, and that there should be an approval number on the mask, and NIOSH should be spelled correctly. Apparently on some of the counterfeit ones, it's not spelled correctly. Providers are also warned to be suspicious of any products that cost more than other masks or are available in very large quantities. So let's take a moment and pause for questions.
All right, thank you very much, Deanna. We do have a few questions, so I will just get right into those. Could someone explain when Kent County would meet criteria to go to a level D?
Well, that's a great question. We can never identify that very clearly because we're not read into what the real methodology is for determining that. It is not just the county positivity rate that CMS uses. It has to also do with other indicators and overall caseload. So if your caseload's still pretty high, it is, so no, the answer is no. We cannot tell you when you're going to go to a D. A lot of counties rather, have moved to D in the last week or so. We see more and more Ds over time. But as I said before, there's still 38 counties that are E level. And I really can't anticipate it. I don't know what the rules are really very clearly. It seems to me that they may even have changed over time about how MDHHS makes their determination.
On the Michigan Safe Start map, Grand Rapids region is D, but then when you click on it, it says Kent County is E. What do we go by?
I'm sorry, can you repeat that, Blake?
Yeah, that's fine. On the Michigan Safe Start map, Grand Rapids region is level D, but then when you click on it, it says Kent County is E. What do we go by?
To be honest with you, I have stopped looking at the map itself. I know the map is divided into regions, and then so you have to make sure that you're not looking at the region level versus the county level. But on the very top of the My Safe Start map page, there's a link to a kind of Excel file-looking spreadsheet that'll tell you the actual rate, and I think it's like 2 or 3 columns over from the name of the county. And that's what I would go by. I've stopped looking at the My Safe Start map. It's kind of been problematic itself. I would go to that grid, and again, that link is at the top of the page that has the map on it. And it'll tell you county by county what the positivity rate is according to the state data. It'll tell you about caseload. It has a whole spreadsheet of information about each county, and each county is listed as an A through E level, and I would use that.
Okay. I have found it a struggle to have our staff members receive the vaccine. I wondered if others are finding this and how they are helping to promote this. Thanks.
I have not heard anything specific about that for a couple of weeks. I do know that some facilities are struggling more than others, and I do know also that Leading Age has put out an awful lot of materials to help with vaccination acceptance by staff. If any other members want to weigh in about what might be working for them, or if they're continuing to have problems, we'll certainly let that member know.
Okay. Our local health department asked if we were interested in doing our own. Option 3 you mentioned, but sounded like they may receive it and store it and then distribute to us on days we would hold a clinic on our campus.
And I did hear that from other members as well, that there have been some options out there. I guess I believe that if you actually administer it yourself, you do have to register in MICR, and that's the thing that everybody has kind of been concerned about, because it's a long process. We can send out the instructions to enroll in MICR for anyone who's interested, and perhaps that is an option that they're moving forward. It does feel like that might be an option. But then again, it also depends on what your plan is, and I'm not sure if the retail pharmacies are going to do that or not. So I'm awaiting for guidance, but if you are planning on administering it yourself, I believe you do have to be registered in MICR.
Okay. A double mask for healthcare settings or general public?
You know, that's not very clear. There was nothing that came out that said healthcare settings should or shouldn't do this. Obviously, if you're wearing an N95 mask, you don't need to do it. But considering the worry about the variants, to be honest with you, if it were me, I would be double masking right now. And one of the best options, I believe, are 2 surgical masks or a cloth mask over a surgical mask. But there's nothing that was directed toward healthcare personnel in that guidance, either from the CDC or the state that I saw. But I would think that protection of those persons would be a very, very important piece to consider compared to the general public.
Okay. The next question was, is it recommended that SNF employees double mask at this point? So I think that you just answered that. Has there been any change in guidance for LTC facilities where almost all residents have had a second dose of vaccine? If not, can we expect any dining activities, visitation, etc.?
Well, there are some dining options already, but that is not a change. And right now, even though we're fighting hard for it, there are no changes in the visitation rules. In fact, last week, Evan Schulman from the CMS nursing home group, he's the director of that group, told Leading Age that indeed they do not anticipate any changes in guidance beyond what's out there now. The reason why is that they don't know, they're not sure that vaccinated persons don't transmit. They're not sure what the effect of these variants are going to be. There are an awful lot of issues and problems. They don't know how long the vaccines will actually protect people. So because of all of those variables, they are very reluctant to change the plan for visitation. And even though MDHHS hasn't issued a statement about that, we believe that that's what's in their mind as well. They have a scale now of when you can open visitation, although it seems pretty rigid to us, and we're, as obviously from earlier in this program, you know that we are advocating for more visitation. The reality is that right now the state is going to use its current method of categories for opening visitation. We are hoping to be able to advocate and effectively change that, but as of right now, those are the rules.
Okay. Most places should have MCIR already for reporting flu vaccines.
Yes, that's true. A lot do, but I do happen to know that many facilities don't, especially facilities that are not nursing homes.
Do you know the percent of people over the age of 65 that have received first and second dose?
I can find that for you. I do have the numbers in the slide. I don't have the percent, but that's something that we could calculate for you, but off the top of my head, no, I don't have that, but I can find it.
Okay. We are directing new staff to register with one of the retail pharmacies or health department for vaccine, stating they are a healthcare worker. They are not getting calls back to get an appointment.
Well, that might be because there's not a lot of vaccines. I'm not sure. We will we'll follow up on that with the department and see what they say. However, we do know that there are wait lists almost everywhere. Sadly, it's true.
Okay. Also, we saw guidance that says no cloth masks in healthcare settings. So would this now be allowed if our staff double mask, one cloth and one surgical?
I would think so. I mean, you're adding more protection to a surgical face mask. So I think that when they say no cloth mask, they mean a single cloth mask in a healthcare setting for anybody other than a visitor or a resident. So yes, I think that you have guidance that tells you you can do that, even though it's not specified for healthcare workers. It's an added level of protection.
Are those facilities who are able to have visitors requiring them to double mask or wear an N95?
I could let some facilities respond to that, but not that I'm aware of. Not that I'm aware of.
Okay. So should we interpret the double mask as a recommendation or a we must do it per MDHHS?
They did not put guidance out specific to healthcare professionals, so I would say it's a recommendation at this point. I think that if they really want you to do something that they're going to mandate, they're going to put out an epidemic letter.
Okay. It looks like that was the last question for now, so we can go ahead and move forward.
Okay, we have a few more updates, and I'll try to be brief because I know we're running late. This is kind of an important one, though. This is the CDC guidance on quarantining, and this has come up before. The CDC updated its guidance for quarantine of persons who have been vaccinated. Community persons, and note that, persons in the community do not have to quarantine if exposed to the virus when they've been vaccinated within the past 90 days and they have no symptoms. These persons need to be at least 2 weeks after the second vaccine dose. However, note that this new guidance does not apply to nursing facilities or other healthcare settings. And the link for this new guidance is at the bottom of the page. There are some exceptions to this, which we'll cover a little bit later. So they put out these two different guidance that are slightly conflicting, but really I think one is just a further explanation of this guidance, and we'll talk about that. So, return to work criteria. They made some small changes to several of these recommendations. The return to work criteria for healthcare workers now include specifically precautions for employees who may be immunocompromised. These persons who are immunocompromised have been addressed before, but not when they were employees. They strongly suggest that any plans for return to work be discussed with an infection control expert with a consideration to keep them in quarantine for at least 20 days after symptom onset. They've also identified that there have been some problems with using pulse oximetry to monitor the clinical status for COVID-positive persons or suspected persons. They have found that in dark-skinned persons, it's less accurate. And so you really need to look at all of the symptoms that's going on with a person in terms of their respiratory status and not just rely on pulse oximetry. Some COVID-positive persons have had skin discolorations and rashes as conditions due to the virus. And they're still studying yet how likely reinfection could be happening in the first COVID type virus, as well as in the variant viruses. So they're studying that specifically because they really don't have enough data on reinfections. And lastly, they identified that COVID-positive persons who remain asymptomatic for 3 months following the diagnosis should not require testing or quarantine. I think that we all understood that from the beginning, and I know we've discussed it with a lot of our members and have acted on that policy, but now they've put it in writing. So while the CDC has identified that staff or residents with high exposure should still be quarantined, they are allowing vaccinated staff to continue to work on site, but only as a contingency strategy if you have staffing difficulties. So we're not sure what the surveyors would say about this at this point. This is just from the CDC. The guidance that identifies what a higher risk exposure is linked on the page. The information and criteria for needing a contingency strategy for staffing is also on the page. And the overall link about these mitigation strategies for staffing is also at the very bottom. So we suggest that everyone review these pieces, but in general, for most facilities, asymptomatic but vaccinated staff still have to be quarantined if they've had a high risk exposure. You're going to have to meet some additional criteria not to do that. MDHHS yesterday sent a reminder out to long-term care facilities to review the December 8th visitation guidance, as many counties have moved out of level E. There's no change in the overall guidance, and so we're not going to go through this. There's nothing different here, but they want to make sure that everybody's aware of what the rules are for visitation, and the link to that guidance is on this page, along with the link to the MySafe Start map. This week, the department also issued a reminder that when visitation for ADL visits or visits that for persons who need assistance in communication, visits for serious conditions or hospice, that if any of those visits are denied, those denials must be in writing. And that must also include the rationale for the denial. And the only reason for not documenting that is if the visitor is tested positive. And the copies of these notices must be submitted to both MDHHS and the Long-Term Care Ombudsman. And those email addresses are at the bottom of the page. As a reminder, that's not new. HUD issued a few new reports this week. One of them was a study on risk factors for COVID and HUD-assisted programs. They identified the degree of additional risk for persons in congregate settings, which are also sometimes crowded residential facilities. And of course, much of the risk is due to age and pre-existing medical condition. So we've listed the risk levels here from that study and a link to the study for anyone who might want to review it. This graph was also included in the HUD study, and it identifies the predominant age groups in HUD settings. And you can see that there's a large number of elderly persons in these HUD-assisted buildings. And thus there's higher risk for transmission of COVID. The goal of this report is really to push for immediate access to vaccines for these populations. HUD has also announced a webinar for February 23rd on housing counseling services. These services are intended to help tenants deal with the impact of COVID. The link to the registration page is here on the slide. And our last update for today is on nursing home reporting. If you remember, there was a glitch last week in EM Resource, and the data upload from Michigan to NHSN had some difficulties. This week, the data is again due this morning to EM Resource, and the state suggests that everyone log into NHSN and check their data for accuracy tomorrow. And that ends our updates for today. We'll take any final questions.
Okay. CDC said that residents should not skip quarantining after exposure, even after 14 days after the second vaccine. It says that healthcare workers can skip the quarantine in that situation. So is that still appropriate? It says that residents and inpatients should not skip it. It didn't say that staff shouldn't skip it.
Okay, if I understand the question correctly, I think that you have to go back to the exposure level risk, and that is a link on the slide that we just talked about a few minutes ago. So it depends on the level of exposure that a staff person would have. If they've simply been exposed with all of their PPE on, you are correct. The old CDC guidance would hold.
Okay. The challenge with visits being allowed to support ADLs is that every family would like to do these visits and everyone could qualify, as there are no other criteria that to support ADLs.
Well, the original guidance, which I think still holds, and I would have to go back and look at it, does require and CMS's take on essential caregivers, which is what they would call these ADL visits, does require that there would be perhaps some negative impact if these visits were not made. And if I'm not mistaken, you're still supposed to do that. I can check because the visitation guidance, as we all know, has morphed over time. But I had thought that that was still the case. We can look into it, but we do understand also that everyone wants to do ADL visits, but there does have to be, I think, a need for that. And it needs to be based on the individual needs of that person. But we'll look into it further and perhaps talk to MDHHS about where they are with that and follow up.
Okay. CDC defines exposure as HCP who had prolonged close contact with a patient, visitor, or HCP with confirmed SARS-CoV-2 infection. So if a staff member says they were around someone outside of work who later tested positive, does the 14-day quarantine apply? It looks like, according to the grid on CDC, they would be allowed to work.
Again, if you have to follow the grid, so I couldn't track all of that scenario very well, just hearing it, but you have to follow the grid. So if the grid implies that it is not a very high risk exposure, yes, the guidance that allows staff to continue to work is still in effect.
Okay, this is another thing about the CDC. This is the wording from the CDC. These criteria could also be applied when considering work restrictions for fully vaccinated healthcare personnel with higher risk exposures as a strategy to alleviate staffing shortages. Of note, exposed healthcare personnel would not be required to quarantine outside of work. I'm sorry, but I'm confused. It says even those with higher exposures don't have to quarantine after the second vaccine. Am I missing something?
Let me respond to that separately. Those were a lot of words for me to track just by hearing them. So I will gather your question and respond to you individually and perhaps copy the listserv.
All right. So with that actually looks like that was the last question. So if you do think of anything after the webinar has concluded, you can always email Safe and Calm, Dalton, or Deanna at leadingagemi.org, and we will make sure to get any questions answered for you. So with that, at this point, we would obviously like to thank Ashley and Don both for joining us today, and we would also like to thank Dalton and Deanna for all their information. And now we would also lastly like to thank the 100 members and participants that took time out of their busy schedules to join us for today's webinar. We appreciate everything you guys do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. With that, I believe that is the end of our webinar today. So our next one will be next Wednesday at 10 a.m. Eastern Standard Time, and I believe that is February 24th. So we will see you all then. Thank you and have a great remainder of your day.
Stay warm, everyone.
Take care.
Thank you.